So this video we're discussing shoulder function, what is normal and how should it work. So as ever, everyone's different. So how your shoulder works depends on your sports, your age, your previous injuries, what activities you do, etc. But we have global sequencing that we would expect to see in normal motion. So when looking at the shoulder, we've got to look at it as a whole. So you've got to be we have to be looking at the SC joint, we have to be looking at the AC joint. We've got the glenohumeral joint, obviously, and then we've got the scapulothoracic, which isn't a joint, but is probably the most important part of how the shoulder works. So they're the four different entities that we have to be looking at when we're looking at shoulder function. Adding on top of that, we've got to know what the elbow's doing, we've got to know what the neck's doing, we've got to know what the thoracic spine's doing, and then we can put in the whole sequence of things. But we want to start off local and then work out from there is probably the easiest way to work. So let's start with the scapula. Scapular motion, as with anything, is three-dimensional. So we've got to know what motions occur at the scapula. So we have an anterior or posterior rotation or tipping, depending on which way, which book you read. We have an internal and an external rotation, so the scapula on the rib cage rotating, and then we have an abduction or an adduction in the frontal plane with the scapula. Now the scapula is not flat, so we have to remember that it is a concave surface, so the motions are not flat on flat, so they're never going to move purely in one plane. What we also have is then we have translations. So we can have an elevation and a depression, which again, because it's not flat, does come into a more than a single plane of motion. But there is that translation of the scapula on the rib cage. And then we have protraction, retraction, which is more a combination of probably frontal plane and transverse plane, but there will be some anterior and posterior tipping with that. So you can look at it in terms of, right, there are 5 different ways in which the scapula can move. So that's a lot. So do we need to remember each one? Not particularly. We need to remember that there's going to be a combination of all those motions occurring when we move our arm into different positions. How should they move when we lift our arm in different positions? Again, will depend. If we're going through a flexion motion, we're going to have more glenohumeral joint motion and less scapulothoracic. As we work around more laterally, the scapular motion increases relative to the glenohumeral joint. So flexion, we get more humerus moving than scapula, and then as we come round, we're going to get more of a scapular contribution. Depending what you read, different motions will kick in at different points. So generally 0 to 40 or 0 to 60, 0 is by your side, we're coming up to 60 degrees. The majority of that is going to be done by your humerus moving on your scapula. From that point on, then your scapula is going to be kicking in more. And generally, especially in the frontal plane, your scapular motion, the ratio slightly changes through the motion, but is most dependent, the scapula is a bit we depend on most between 90 and 120 degrees. Okay, so that's where we need our scapula to contribute most to getting our arm up into that position. Okay, 90 to 120 degrees. That should ring some bells with some of you. So as we read in our books, the painful arc or impingement syndromes, etc., where do they occur? 90 to 120 degrees. What does that tell us? We need a scapula that moves very well in that position. This might start to lead you down a certain thought process when you see someone who's got funky mechanics or pain, etc. Right, is the scapula moving as we need it to do? And dissociating, is it a scapular problem? Is it a glenohumeral joint problem? Is it an SC joint problem? Is it an AC joint problem? is hard to do. But if we have to understand the initial mechanics of how that works. So the other part of when we're moving or we're lifting our arm up is what the humerus is actually doing. And it's never just staying in a fixed position, okay? There is always a rotation, whether you can see it or not, with the humerus in the transverse plane as we're lifting it up into these motions. So generally we're looking at an external rotation of the humerus as we come up through these different planes of motion. So the humerus has to be externally rotating as it's moving. We have to be getting the translation and the rotation in the glenohumeral joint, and the scapula has to be moving with us in all three planes to get efficient motion. Where it gets a little bit trickier is when we're going into rotation. So we're going to internal rotation, so putting your hand behind your back, or external rotations if you're going to reach for a seatbelt, you're reaching for your coat, etc., you're throwing. The percentages start to change, but we know the scapula has to move. Is the scapula moving too much? Or is the glenohumeral joint not moving enough? Is the scapula not moving enough? A lot of that is experience. We're looking at that compared to what we perceive as normal. How does it change when someone's injured? How does it compare left to right? Might give you a bit of an idea. But you have to have a ballpark of what should be happening and how should it look. Does it look easy? If someone's reaching behind their back, do you see a huge elevation and anterior rotation to be able to get them into that position? Do they flex? If you're seeing that, you'd say, right, maybe the scapula there is the compensation because the glenohumeral joint does not have that internal rotation. The percentages of what should be happening at the glenohumeral joint and the scapula get tricky at those positions. So I don't think there is a number of how much the rotation should be. Maybe it is close to that 2-to-1 ratio that we see in the frontal plane in terms of the humerus moving 2 degrees, the scapula moving 1 degree. But it's very hard to measure in the transverse plane. So we've got to think, where should that motion be occurring and how are they getting to that position? Once we understand this, then we can start to look more at dysfunction, where we think the dysfunction is, and then trying to help them out.